This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today. And today we want to talk about some of the new technology that's used in the treatment of breast cancer. We're delighted that we've got with us Dr. Amelia. She is a breast surgical oncologist and medical director of the breast program at Texas Health Harris Methodist, located in Fort Worth. Dr. Tawa, welcome to the show.
Well, thank you both so much.
For our listeners, can you explain what this new technology is and how it's being used?
You know, as we all know, breast cancer is the most common cancer among women, and 1 in 8 women, unfortunately, will develop it in her lifetime. You know, we look at our audience today, and most likely some of these people listening have battled this terrible disease, or they've had to experience a journey of breast cancer through a loved one or even a friend. And whenever we look at breast cancer, surgery is the primary treatment. And patients ultimately have 2 choices for treatment, which is either a mastectomy, that is the complete removal of the breast, or a lumpectomy, which is removal of the tumor with healthy tissue around it. The new technology that I'm currently using at Texas Health Harris Methodist, it's an FDA-approved machine, and it's actually used in the operating room on the lumpectomy specimen. And what it does is it evaluates in real time in the operating room the margin assessment. What does this mean? Well, it means that sometimes breast cancer can't be seen or felt, and I can actually look at the tissue removed during the operation and detect if the amount removed is adequate or if additional tissue should be taken at the same surgery. So the possibility of a patient having to return for a second surgery is extremely low whenever I utilize this equipment.
So as you use this equipment, do you still need a pathologist involved in this kind of surgery?
Absolutely. Pathology involves a physician who's trained to examine specimen and tissue samples for a diagnosis, and that's still a critical part and process in all cancer operations. This technology does not replace the need for pathology, but again, it provides that real-time information on the margin status of a lumpectomy before closing and ending the operation, which gives added assurance to the surgeon that the cancer is definitely removed and there's no residual disease that could possibly exist. The process is non-toxic and it's non-destructive to the tissue samples, so it preserves the lumpectomy specimen for traditional pathology review to take place.
How does it actually work and distinguish healthy tissue from tissue you have to remove?
So it really goes off the mantra of seeing is believing. This machine uses OCT, which is optical coherence tomography, and that's actually been around since 1991, and it's been previously used in specialties such as ophthalmology, cardiology, and dermatology. OCT produces images very quickly on a screen, and the resolution of these images that are displayed are actually 10 times higher than standard X-ray or ultrasound images and 100 times greater than that of MRI. So what it does is it allows surgeons to look at the tissue right then and there rather than waiting days after pathology processes the tissue and looks at it under their microscope. And again, in real time, we're able to visualize if additional tissue needs to be taken because we may see cells or cancer approaching what we call the margin.
Do you use this technology in all types of breast cancer surgery? For example, do you use it in a mastectomy?
So that's actually a great question. And right now, this device is only utilized for lumpectomy specimen. The reason being is it's limited in the diameter that it can scan for the tissue. It can scan up to 8 centimeters, and the majority of mastectomy specimens, which includes the complete boundaries of the breast, are larger than 8 centimeters. So currently the technology is being utilized for lumpectomy because it's important as it's being used to look at the margin assessment, which is where the margin is a concern. Again, the lumpectomy is where we remove the tumor with healthy tissue around it. So this machine is allowing us to visualize that tissue and ensure that we are incorporating healthy tissue and not leaving cancer behind.
As a surgeon, how has this changed your surgical experience?
I can honestly I can honestly say since I've been routinely using this piece of equipment since August, it's transformed my surgical processes for my breast cancer surgeries as well as for all of my lumpectomy patients. A lumpectomy is a breast cancer surgery that preserves the cosmesis of the breast as well as the functionality, but it has similar survival rates as a mastectomy. And in order for this procedure to be successful, again, there has to be that realm of healthy tissue around the removed cancer. And one of the risks of this type of surgery is residual microscopic disease remaining after the surgery, which is known as that positive margin. Unfortunately, if a positive margin exists, this can result in the patient requiring a second surgery to remove that involved margin or tissue. And I can say personally that telling a patient she has cancer is one of the worst conversations that I have to have, second only to telling her that we didn't get all the cancer on the first surgery and we have to go back for another procedure. Current technologies just don't have the capabilities to visualize microscopic disease on margins, but OCT can quickly demonstrate on a screen up to 2 millimeters subsurface imaging of all excised tissue margins right in the operating room. So it enables surgeons to make informed decisions when it counts the most. And as a surgeon treating this horrible disease, I want to do my very best. And if I can utilize technology and capacities like this to have better outcomes and save my patients the emotional and physical trauma of going back to the OR, then I'm going to do my very best and utilize this machine.
So for your patients, when the surgery is complete, do your patients still require radiation or chemotherapy?
So that's dependent on a lot of factors. And in breast cancer, that's one of the amazing things that it has to offer is that all treatment and all treatment plans are individualized and multidisciplinary, meaning that we incorporate several physicians of different expertise to come together and have consultations with our patients and discuss their treatment plans and their very best options. The decisions regarding radiation and chemotherapy are based on the final pathology that we retrieve from the surgery, and also a lot of factors that are determined from that pathology, which incorporates size, characteristics, and even prognostic panels of the tumor itself. So whenever we look at a lumpectomy, the standard of care still shows us that radiation is utilized as an adjunct. And what it does is it can decrease the chance of loco-regional recurrence for these patients. However, we've also identified in several studies that not all patients who have a lumpectomy for either non-invasive or invasive breast carcinoma require radiation. That's where we involve radiation oncology experts, and we also, again, look at our final pathology.
This has been Dr. Amelia Tower from Texas Health Harris Methodist Hospital in Fort Worth. She is a true innovator in breast cancer treatment. When we come back, we're going to talk about our heart with Dr. Bradley Leonard from Decatur on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're delighted you're with us today. We want to talk a little bit about your heart, a heart attack, some of the things you need to know, and some of the preventions that you can do. We're going to be talking with Dr. Bradley Leonard, who is the medical director of cardiology at Wise Healthcare System. Dr. Leonard, welcome to the show.
Thank you very much. It's a pleasure to be here.
If someone, for example, is having their annual physical and there is a problem like blood pressure that's quite elevated, some pain, some uneasiness, is that when you should consult a cardiologist?
I think that's an excellent question. Many general practitioners are well equipped to handle hypertension. I'm often referred patients where the family practitioner or internal medicine doctor or primary care physician has had a hard time controlling their blood pressure. And make no mistake about it, hypertension is the number one risk factor for cardiovascular disease in the United States.
So if a patient comes to you and you have difficulty with the hypertension and you sense other symptoms, sometimes you do what's known as a cardiac catheterization. What is that procedure?
Sure. Let me step back just for a minute. There are 5 major risk factors for coronary artery disease: hypertension, high cholesterol, diabetes mellitus, smoking, and of course, a family history. And the family history is for premature coronary disease. We know that disease tends to run in certain age categories. And when we see members of the immediate family, brothers and sisters, aunts or uncles or parents, that have had coronary artery disease or heart attacks in their 40s, 50s, or early 60s, that's also a risk factor for that patient. If they come to me and they're having episodes of chest discomfort and they have some risk factors, we will usually start with some sort of a functional test, like a stress test, to find out whether or not the chest pain is related to coronary disease. Because, of course, there are lots of things that live inside your chest that can cause chest discomfort. For example, gastroesophageal reflux disease can often feel just like a heart attack. But once we decide to proceed with the cardiac catheterization, that's a procedure that's done usually on an outpatient basis in the hospital. And it's where we stick small catheters. They're not much bigger than a large piece of spaghetti into one of the arteries, usually an artery of the wrist or an artery at the top of the leg. And we can actually go inside the heart at the opening of the coronary arteries and inject X-ray dye in there. And under fluoroscopy, we can actually visualize the artery and all of its branches. The procedure itself is very safe and is usually very quick.
So when you do the catheterization, can you check all the arteries or do you go to a specific artery to check it?
That is an excellent and incisive question. I was trained very classically in cardiac catheterization and was taught that you do the exact same number of pictures on every patient every time in the same order. That's for a very good reason. If you suspect it's one artery and not one of the other arteries, you can miss something in one of the other arteries. There are 3 major arteries in the heart. And so I was taught and still perform lots of catheterizations where you look at all the arteries the same way every time and then sort of step back and look at your pictures and make sure you don't miss anything, because sometimes those blockages can hide.
When you do detect a blockage, people hear that, well, we're going to put in a stent. What is a stent and when do you think they are appropriate?
The history of stents are very interesting. Prior to stents, back in the late 80s, all we had were balloon procedures. We would put a balloon in the artery, blow up that balloon, and it would sort of, if you will, mush the blockage up against the walls of the artery and sort of open that area. The problem with plain balloon angioplasty was that about 30 to 35% of patients would re-narrow that artery within 6 months. So that was obviously quite a failure. Imagine if you went out to buy a new car and the guy who sells you the car says, I think it's a nice car, but you got about a 1/3 chance that it will break down within the next 6 months. But that was the best we had at the time. Stents really became available in this country in the early 90s, and it's a small metal scaffold. Imagine a piece of chicken wire or cyclone fence rolled into a tube. It's placed on the balloon. The balloon is then placed within that blockage. As the balloon is blown up, the stent is expanded, helps to keep the walls of that artery open. The other real big advancement in stents was when we began to develop drug-coated stents. These are stents that have a small layer of polymer on them within which a drug is placed that helps to prevent re-narrowing. So now with the modern day 4th generation stents, once we put that stent in the artery, your risk of re-narrowing that artery is usually less than 5%.
So if you have a patient that you have done the catheterization and you've determined you need to put a stent in, is that it? Or do you sometimes have to go back and redo the stents to prevent a heart attack?
Well, that's an excellent question. I think it's very important once the catheterization itself is complete, and I can usually complete catheterization in under 12, 13 minutes. It's important to step back and take a look at the entire picture. What's the overall heart function like? What's the pressure inside the heart like? And what do the arteries look like? In some patients, particularly patients with blockages in all three vessels, we often have to recommend bypass surgery. If it's usually just one or two vessels, we will often put one or two or sometimes three stents in at a time, and then proceed to make sure that the patient does well. So it's very important for them to be on appropriate medications immediately after stent placement and for them to have active follow-up. Because like I said, there's 5% of patients that will re-narrow within that area or develop a new blockage somewhere within that artery or within another artery sometime within the next 6 to 12 months.
You know, you mentioned in your answer some of the medications that you could be placed on after you put in a stent. Can you elaborate a little bit on what are some of the common medications?
Absolutely. And these are critically important. Probably the single biggest bang for your buck in all of medicine is aspirin. So it's critically important that you take a baby aspirin every day. More importantly, because these stents are metal, and that's obviously sort of a foreign body inside the heart, it's very important to give that stent time to reline. What I mean by that is a very fine layer of cells will grow inside that stent wall. Think of it sort of as a layer of saran wrap. That helps to block off that foreign body so that your body thinks that it's just another part of the artery. In order to give that stent time to do that, it's important that you go on what's known as dual antiplatelet medication. That's usually a baby aspirin, and then either one of two drugs, Plavix, the generic of which is clopidogrel, or Brilinta, or sometimes a drug called Effient. Traditionally, the FDA mandated that we place patients on both of those antiplatelet drugs for 12 months. Because of some work that's done, particularly with these new fourth-generation stents, most of us are using only 6 months or sometimes just 1 month of dual antiplatelet therapy, and then you drop the aspirin and remain on either Brilinta or Plavix long-term. This is critical to prevent a very bad outcome, which is known as subacute thrombosis. If you don't take both of those drugs immediately after stent placement, you run the risk of developing a clot within that stent. Fortunately, as long as you take that medication, those two medications, that's very rare.
That is so important. So what you're saying is once the stent is done, there's still a lot of work to be done. It's up to the patient to fill those prescriptions and take as prescribed. Didn't realize clots could develop.
Absolutely. And what I like to tell patients is there's only so much that I can do. Maybe 10 or 15% of the work is done by myself in the cath lab. 85% of the work is done by the patient. That involves making sure they get their prescriptions filled, taking the medications as prescribed, making their follow-up visits on time, and then, of course, engaging in healthy lifestyle activities, maybe diet, exercise. There are other medications that are often taken in order to lower cholesterol and to engage in a cardiac rehab program.
You know, you mentioned that cardiac rehab. What is cardiac rehab?
Cardiac rehab is an excellent program that I strongly encourage all of my patients to attend. And in fact, I tell them, in 34 years of practice, I've never had a single patient come back to me in the office and tell me that cardiac rehabilitation had been a waste of their time. It involves usually, for example, with Medicare patients and for most commercial insurance patients, a total of 36 sessions, 3 times a week for 12 weeks. It usually occurs in a setting that sort of looks like a typical gym that you would go to. There are exercise physiologists, nurses, physical therapists in there that usually begin a program of graded exercise. And there are multiple advantages and benefits to going to cardiac rehab. 1, patients get improved exercise tolerance. 2, they lower their blood pressure. 3, you often see a decrease in symptoms. 4, there's a lot of help to help you with smoking cessation and appropriate diet. Many patients will find a lowering of their cholesterol. And I think possibly most importantly, it gives the patients an improved sense of well-being. They realize that I put the stent in, but they're the ones doing the hard work in order to get in shape, lower their cholesterol, lower their blood pressure. I think it's very important for patients to realize that they're an important part and an active part in their own healthcare.
We're talking with Dr. Bradley Leonard, the Medical Director of Cardiology at Wise Health System. When we come back, we're going to talk about another tool that they have in their toolbox to help prevent a heart attack before it happens. So stay with us on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation with Dr. Bradley Leonard, who is the Medical Director of Cardiology at Wise Health System in Decatur. We're talking about preventing heart attacks. And if you didn't catch the previous interview, it is on our podcast and our YouTube channel, The Human Side of Healthcare. Steve?
For our listeners out there that hear frequently, I'm dealing with heart failure. What is the difference related to heart failure and a heart attack?
That's actually a very complex question. Heart failure in general, in the past, has meant patients whose pump function of the heart is not working as well as it should. This can lead to an elevated pressure in the heart, which then backs up into the lungs and causes people to become short of breath. What we're finding more and more now is that traditionally those were people that had weak hearts. The estimate now is that at least 50% of those patients have strong hearts. In fact, the heart's almost too strong. And as the muscle becomes stiff, the pressure inside the heart rises and again can cause problems with shortness of breath. The great thing is there's an entirely new class of medications that have proven to be extraordinarily successful in treating patients both with what we call systolic heart failure, which is a poor pumping heart, and as I mentioned, diastolic heart failure, where the pumping action of the heart seems to be normal, and yet it has very high pressures. And these were all brought to the fore with the recent update from the American College of Cardiology and the American Heart Association and how we manage congestive heart failure. Traditionally, that was a very bad diagnosis to have, but more and more we are seeing incredible improvements with modern medications.
Does the exercise, the rehab, help that heart failure situation?
Another great question. I have been involved and ran cardiac rehabilitation programs in the past, and I have been absolutely amazed at the kind of improvement patients can see. I at one point ran both a cardiac rehabilitation program and a pulmonary rehabilitation program. And I still remember, this was 25 years ago, a woman who, when she started, could not make it a quarter of a way around a routine track without having to stop with shortness of breath. And after 3 or 4 months, was able to walk a mile without shortness of breath. So we can see tremendous benefit, both in terms, like I mentioned before, blood pressure control, but also in terms of weight loss and just general strength and conditioning. It's helpful for elderly patients to help with their balance. So I can't stress cardiac rehab and physical activity enough.
What about when people feel tired, but their arteries are clear? So is it that the heart is not supporting what they need for their daily activity?
That's a tough question because there are lots of reasons to feel tired. If it's a cardiac cause, it can certainly be from traditional heart failure with a weak heart. It can be from a stiff heart, and those are patients both with coronary disease and without coronary disease. The other thing we haven't really talked about is patients that have problems with their cardiac rhythm. Some patients have heart rates that begin to be too slow. So even though the heart technically is pumping well, simply their heart rate is too slow. There's something called chronotropic insufficiency, which is fortunately rare but very interesting. These patients will have a normal heart rate at rest, but as they start to exercise, their heart rate won't increase. So they don't get more oxygen to their muscles and they tire out very easily. Those folks are frequently helped with a simple pacemaker, which takes about 45 minutes to put in.
So really, if you're having these symptoms, you need to get a consult. And then where do you start looking? So if, I guess you mentioned the stress test earlier, and then where do you go from there?
There has been a real change in some of this. Traditionally, we used routine exercise stress tests. What we realized back in the 70s and early 80s is that the problem with the routine treadmill stress test is that there are an awful lot of false positives, particularly in middle-aged women. Upwards of 1/3 of tests would appear to be abnormal when in fact there was nothing wrong with their heart. We then moved on to imaging studies. So there's a stress echo where we do a sonogram of the heart before and immediately after exercise to see how the heart responds to exercise. There are nuclear stress tests that look at blood flow to the heart before and after stress. And now, more importantly, we're starting to see more and more coronary CT angiograms, which is sort of like, if you will, a poor man's catheterization. Patients can get X-ray dye injected into a vein instead of directly into the coronary arteries. undergo a CT scan. And with modern technology and modern CT scanners, we can get a really good look at their coronary arteries as well.
You're listening to The Human Side of Healthcare, and we are talking to Dr. Bradley Leonard, Medical Director of Cardiology at Wise Health System. They are located in Decatur, by the way. We're talking about this test called the CT angiogram, and Dr. Leonard, I'm glad you mentioned this. I know you were talking with Steve earlier about the cath lab, but if somebody is in their 50s, 60s, 70s, and this test is available, and it can show those blockages by just getting a CT, basically, is there any reason that anybody should die from that type of heart attack?
Well, that's a difficult question. One of the problems, in fact, one might even say the biggest problem with heart disease, is that fully 1/3 of patients, their first sign of heart disease is the day they have their heart attack. We learn in medical school to look for symptoms of a crushing substernal chest discomfort that radiates down the left arm or up into the jaw. But in fact, a lot of patients have very few symptoms. As you will recall, women particularly will often have what we call atypical symptoms. They may come to the office and simply say, I'm tired or I'm short of breath. Traditionally, we would not be as attentive to that. Nowadays, what we realize is because women have atypical symptoms, our antennae are up. So when we hear those kind of symptoms, we think, obviously, as a cardiologist, I think, let's make sure it's not the heart, because there are lots of other things that can cause those symptoms, but let's make sure the heart first. One of the things we haven't talked about are coronary calcium scores. These could be obtained often without even a prescription for as little as about $99, and it looks at calcium within the coronary arteries. Now, please understand, this is a very non-specific test, but it has very high what we call negative predictive value. If you get a coronary calcium score and your score is 0, in other words, there's no calcium in your coronary arteries, your risk of a major adverse cardiac event, what's known as MACE, over the next 10 years is less than 1%. It's a pretty good screening test. Now, if your test comes back abnormal and your score is 200 or 300 and you have some calcium in your coronaries, it doesn't necessarily mean you have bad coronary disease. Calcium is simply a marker for plaque. But between a coronary calcium score, a coronary CT angiogram, there are ways that we can now look at the heart relatively non-invasively without having to do a catheterization. I think the most important thing, though, is for people to be mindful of their bodies. And if something is abnormal, if their blood pressure is high, if they're feeling tired, if they're having chest pain, if they're having unusual shortness of breath, by all means, go talk to your primary care physician about this. And if he feels or she feels the need, please come see a cardiologist.
Let's jump back over to that rehab and that exercise side for a second. Somebody listening is in their, say, 30s, 40s, even 50s, and they still have time, and they want to take the very best care of their heart going forward. You have that epiphany moment of, I've got to really start getting a hold of my health here, and I don't want to have the heart attack that they're talking about. What would you prescribe for them? What would you tell them to do to change, to take the best care of their heart?
Well, as we mentioned before, there are 5 major risk factors for the development of coronary disease: high blood pressure, high cholesterol, diabetes, smoking, and a family history. So the first thing I say is, unfortunately, you can't change your family history. You can't pick your parents. And so you're sort of stuck with that risk factor. The other 4 risk factors are manageable. If you smoke, quit smoking. By all means, go to your primary care physician, get your cholesterol checked, get your blood pressure checked. Remember, one of the reasons that coronary artery disease and heart disease is by far and away the number 1 cause of death in the United States is that 2 of the biggest risk factors, high blood pressure and high cholesterol, don't make you feel bad. So you can run around with a blood pressure of 165/95 and a cholesterol 300 for 20 years and never really feel bad. And then all of a sudden you have to deal with the manifestations and the long-term consequences of those things. So what I tell young patients is, if you smoke, quit smoking, eat a healthy diet, get some regular exercise, and see your physician once a year.
Pretty good prescription. Women go get a mammogram for breast cancer detection. You go get a colonoscopy to see if you have colon cancer. Should these tests that you've been mentioning in this interview be part of a repertoire of normal, regular checking up on your heart so that you catch it before it's too late? Like you say, the first sign of heart problems is, death. Can't we get ahead of that curve?
Thomas, that is an excellent question, and we have looked into this for many years. There's something called the United States Preventative Healthcare Task Force, and they've got a great website. And they're an independent group of physicians that have no ties to pharma, that have no ties to device companies, and they get together periodically, and they're the ones that figure out when you should get your mammogram, when you should get your colonoscopy, when you should get these screening tests. And in fact, a routine exercise test is not recommended as a screening test, simply because even with the advent of stress echoes and nuclear stress tests, there's still a finite false positive rate. The most important thing you can do is to control those risk factors. In other words, put the best cards you can in your hand in your favor. Coronary calcium scores are not an unreasonable test because they're relatively inexpensive and anyone can get one. As I said, if your score comes back 0, you're virtually guaranteed 99% of being risk-free for the next 10 years. Coronary CT angiograms, cardiac catheterizations, nuclear stress tests, stress echoes, those are all significantly more expensive. And so we don't generally recommend them as screening tools. And in fact, the U.S. Preventative Healthcare Task Force has recommended against those things. My area of expertise, cardiovascular disease, is the classic example of an ounce of prevention is worth 10 pounds of cure.
We've moved outside the Metroplex to Decatur, the WISE health system, to get some wise advice from Dr. Bradley Leonard, the medical director of cardiology there. And we thought, when do you get to talk to somebody so eloquent and so knowledgeable about preventing heart attacks? Well, we wanted to learn more, and that's exactly what we're going to do in the next segment, and he is going to tell us one of the top ways, in fact, the best way to prevent a heart attack, and it's not to quit smoking. Find out what it is next on the human side of healthcare.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
We're continuing our conversation now with Dr. Bradley Leonard, who is the medical director of cardiology at the WISE Health System in Decatur. We found him so insightful that we just kind of started to chat and to talk about how we can prevent heart disease. In the last segment, Dr. Leonard, we were talking about the CT angiography. Well, I've had 2 of them. I've had AFib for 10 years. Yeah, thank you. I mean, I wouldn't wish it on my worst enemy. But I've had 2 of them, 0 calcium scores. Just to me to say that I know, even though I do have one area of my heart that's not working right, that I can go climb this mountain or I can go do whatever physically that I want, and I'm not going to conk over from a heart attack is a pretty good feeling.
I think it's a great feeling, and atrial fibrillation is the bane of my existence. And what I tell my patients is the answer to every question you can possibly have, and they're all good questions, is yes, no, and maybe. No 2 patients are alike. And I think in some ways AFib is sort of like the common cold. The reason we don't have a cure for the so-called common cold is, of course, there are 100 different viruses that can cause the common cold. I think atrial fibrillation is the final common denominator. It's where you end up. But how you get there really varies from patient to patient. Fortunately, we have relatively good medications for it. We have blood thinner medication to help prevent stroke, and we now have atrial fibrillation ablation procedures. But it has become endemic in this country, so that I would say 20-25% of all the patients I see, their presenting complaint is atrial fibrillation.
And that's getting younger, isn't it?
It's getting younger, and I think it's a combination of poor control of hypertension. Let me talk about hypertension for a minute. There's a fascinating study done by the T.C. Chan School of Public Health at Harvard several years ago. And they said, let's take 10,000 patients with all 5 risk factors for coronary disease and follow them for 10 years. Well, we can't really do that. So we're going to have the computer model it. And they used artificial intelligence. So they took 10,000 patients with all 5 risk factors, plugged them into the computer, and at the end of 10 years, estimated how many of those people would have a heart attack, stroke, or go into heart failure. Then they said, let's start over and take away 1 risk factor. Follow them for 10 years. Start over and take away another risk factor. So take away 1 risk factor each time and leave them with the other 4. And I was shocked at the results. I thought for sure smoking would be the risk factor. Not even close. It was hypertension. If you took away hypertension, You lowered your 10-year cardiovascular risk by almost 40%. Smoking, 13%. Diabetes, 22%. Hypertension is by far and away the biggest risk factor. And the tragedy in this country is that we do such a poor job controlling hypertension. And it's easy to control if you know what you're doing. Less than 50% of patients with high blood pressure in this country are treated at all. Of the 50% that are treated, less than 50% are treated to goal. And it's one of the reasons that cardiovascular disease continues to be the number one cause of death in the United States.
What a great wealth of information. Thank you.
One question in cardiac rehab. I've had two friends, and one was 25 years ago, so things have changed, but they've had open heart surgery, and both had temporary bouts of depression. Does cardiac rehab touch on any of the depression that patients have sometimes?
That is a great question, and I'm so glad you brought that up. Post-cardiac surgery depression is a well-known phenomenon. It attacks maybe 5, sometimes 10% of patients. And part of it is because I think, particularly for younger patients, it's their first time they've really faced their own mortality. And they have a lot of questions, some of which they may not ask their physician. Am I going to die? Is this going to shorten my life? One of the things that cardiac rehab does is it's very, and this may be a somewhat pedantic and pedestrian explanation, but it's very life-affirming. You get to sit in there and you get to exercise with other patients, all of whom have had heart attacks or have had heart failure or have had bypass surgery, and you get to see how they improve and you get to see how you improve. Exercise is so critical that there are a number of studies that have been published over the last 20 years that show that in most patients, a rigorous exercise program is as effective as antidepressant medication in the modification of mild to moderate depression. And again, I can't stress this enough. Diet, exercise, going to your physician, making sure your cholesterol and blood pressure are under control are really the keys to prevention of this all too often fatal disease.
You know, I'd like to parlay on that. I had the ablation back in 2013. After that surgery, I had no idea how emotionally involved the heart itself was. But for probably 6 months, I was very emotional, and it kind of upset my balance. And then you find out that a lot of people report the same thing. After a procedure, invasive procedure into the heart, emotions tend to follow. Any idea why that is?
You know, Thomas, if I had an answer to why that is, I would be sort of more like Shakespeare than just a plain old cardiologist. But I mean, seriously, think about it. From time immemorial, go back to Milton or Dryden or Shakespeare. These questions of the heart have been asked by poets and artists and musicians for centuries. So there's obviously some very complex psychic connection between the heart and the soul and the brain. It's interesting you mentioned that. I think this post-procedure depression is probably a lot more common than we see, but a lot of us may be unwilling or afraid to mention it. Somehow that would be a sign of weakness, and I don't want to tell anybody. And as you know, our secrets are what keep us sick. And when we're able to actually go and talk to our spouse or talk to our physician or talk to even a best friend, you know, I'm feeling kind of blue. I'm feeling a little bit depressed. It takes a lot of the power out of that. I just think it's so important to be honest with your physician, with your spouse, with your friends about how you're feeling.
Well, for people who are going through heart issues or family members, keep that in mind, because it's something that, as he just said, you may not understand or they may not let on, but inside it would be a really good thing to check in with them. How are you doing? Because it can be an issue.
And usually with exercise or occasionally with medication, a lot of these things are temporary. I'll tell you, I had a patient who came to me, a surgeon sent him to me. I had not seen him before surgery. I walked into the office. This is a true story. And the guy's in tears. And his wife looks at me and says, "You see this? If you can't fix this, I'm going to file for divorce. He's been like this for 3 weeks." I said, "Hold on a minute." I ran upstairs to the internal medicine doctors and said, "Look, have you got any samples of antidepressant medication?" And they said, "Sure, just go into the drug cabinet and grab some." I came back down to the floor and I said, you're going to take these whether you like this or not. The guy comes back 3 weeks later, and it was sort of like the When Harry Met Sally deal. He's smiling, he's happy, he's riding his bike, everything's great, and his wife says, I want whatever you gave him. The point is, postpartum depression, post-bypass surgery depression, post-AFib depression is a real phenomenon. It's usually temporary, it's short-lived, and by all means, mention it to your physician, because sometimes a short course of medical therapy, you don't have to go see the psychiatrist, you don't have to be on antidepressant medication forever, just for 3 or 4 months, and then we'll taper it off, and lots of times that's all it takes.
I would say hear to that answer totally. It is an issue, and people should take a look at it. And I think that you truly are the bard of cardiology in North Texas.
I appreciate that. I've been here in North Texas for 34 years practicing, and I wouldn't be anywhere else.
Dr. Bradley Leonard from the Wise Health System Indicator. You know, Steve, this is so indicative or reflective that for some reason, urban medicine is somehow better. We just sure disproved that myth, didn't we?
You know, you're so right, Thomas. We're so fortunate to have hospitals in rural communities. And if there is something that is serious that would require that they be transported into a hospital in the urban community, the physicians do it. But let me give you an example. If someone's involved in an automobile accident in a rural area and are taken to an emergency room, they play such an important role to treat that patient and stabilize them, even if they do have to be moved to an urban setting. You know, we really need these rural hospitals for the value they add in their communities throughout America. Please join us next week for the human side of healthcare.